third year PG student in Department of General Medicine, PMCH, Patna, and I present a case of skull-based osteomyelitis. My case is that of a 60-year-old male who came to the medical emergency of PMCH with the complaints of headache of 6 months and left-sided earache for the last 3 months. He was apparently already 1.5 years back, following which he developed severe right earache, which was not associated with any ear discharge. There were no complaints of hearing loss, tinnitus, toothache, or any fever or respiratory tract infections. There were no history of head or face trauma. For the following complaints, he repeatedly took some Ayurvedic as well as over-the-counter allopathic medications and also consulted some local practitioners for 2 months, but there was no relief. In these 2 months, the earache spread to the right temporal region and the right cheek, following which he finally sought professional medical advice. Some initial investigations were done, and finally the contrast-enhanced MRI of brain was done, and the patient was subsequently diagnosed with right skull-based osteomyelitis and right otomastoiditis with involvement of the nasopharynx, and the right maxillary sinusitis with associated right cerebralitis. He was prescribed surgery, and an endoscopic approach in nasopharyngectomy and right cortical mastoidectomy was done, and he was discharged on a tablet voriconazole as the MRI findings and the intraoperative findings were highly suggestive of an ongoing fungal disease. After a brief asymptomatic period of say 1 month, he developed the earache and headache, but this time the symptoms were on his left. From the past 3 months, which were this time associated with some hearing loss. The patient was re-advised surgery, but the patient denied it and presented with the above mentioned complaints to PMCH. My patient is a known case of diabetes mellitus, hypertension and coronary artery disease. His diabetes mellitus, the status was poorly controlled on metformin and glimepiride. On examination, my patient was conscious, cooperative and well attended to time present person. Apart from a bipedal pitting edema limited to the ankle, there was no any abnormal findings in the general examination. My patient was hemodynamically stable at the time of presentation. On examination of the nervous system, there was all the system, everything was examined, and my patient had right-sided cranial nerves were normal, and the left side sensory neural deafness was diagnosed clinically. Rest all the nervous system examinations and all the other system examinations were found to be within normal limits. On local examination of the ear, the left pinna appeared normal with the pre and post auricular areas appearing within normal limits, but the external auditory canal had some mucopurulent discharge and the tympanic membrane could not be visualized. The ear on the right, however, was normal. Receiving the patient in the medical emergency, the patient's glycemic and cardiovascular statuses were stabilized. The patient was put off the oral antidiabetics and was taken upon subcutaneous insulin. The following abnormalities showed that the patient's glycemic status were largely uncontrolled, and the patient also had a moderate anemia. On the basis of his previous investigations, apart from the ongoing tablet voriconazole, my patient was started on IV liposomal amphotericin B in view of the maybe an ongoing invasive fungal disease. And subsequent MRI was done, which now showed enhancing signal intensities in the soft tissue of the left lateral aspect of the base of skull and an enhancing neural thickening on the left tentorium cerebri, which confirmed our suspicion that either the previous therapy was incomplete or it was wrongly done on the patient. Well, this MRI shows the previous findings that I have said right now. Multiple samples were taken and Pseudomonas aeruginosa was isolated, which was sensitive to ceftazidime, and the patient responded quite well to the therapy, and the therapy was continued for the next 2 months.
You should also think of multiple myeloma.
Yes, sir.
Every time. Make it habit. If ESR is more than 100,
yes, sir.
think of multiple myeloma.
Yes, sir.
And patient age was around 60 years.
Yes, sir.
Multiple myeloma is just common.
Yes, sir.
And ESR is very, very helpful in catching the diagnosis. Okay.
Yes, sir.
So since our initial reports were normal and KFT was within normal limits, we excluded multiple myeloma on that.
You have to be cautious because ESR is 100.
Yes,
You
sir.
should think about multiple myeloma.
Yes.
Maybe a patient may having multiple myeloma, maybe silent cyst. Patient may going, you can go more way of aspiration or you just you gamma electrophoresis. Patient can have multiple myeloma.
Yes.